Thank you very much, Angie, and thank you to the SALTS team for the invitation to present today. It's been a very enjoyable and a great privilege, especially to hear from Amy Dowden in the last session. I've been asked to talk about surgery for ulcerative colitis and Crohn's disease. That's a lot to cover, and I'm deliberately not going to try and cover the whole of that subject because that would take far too long. So I'm going to focus on, firstly, decision-making in ulcerative colitis, particularly about pouches or not having a pouch, and then I'll talk a bit more about Crohn's disease and the preparation for surgery, and a little bit about the surgical issues that we're thinking about today with Crohn's surgery. So I'll start off with a sort of hypothetical case to see what you think you would recommend. This is a young lady who I saw in clinic fairly recently. She's now 25, was diagnosed with ulcerative colitis, age 20, and then a year or so ago was admitted acutely with acute severe colitis, didn't respond to medical therapy, and ended up having an emergency laparoscopic colectomy with ileostomy formation and leaving the rectal stump in place to be dealt with on another occasion. So the current situation is that she's very well, she's off all drugs, she's got an ileostomy, which she doesn't really like, but she manages it very well, and she gets some blood and mucus discharge from the out-of-circuit rectal stump. So the question is, what would you recommend? What should we do next? And as I suspect most of you know, there are a number of options. Removing the rectum and an ileoanal J pouch is the sort of conventional option. A small number of people can be considered to have an ileorectal anastomosis. If the rectum is mildly diseased, that's an option. You could say, you're 25, you're well, let's leave it for 10 years and then do some form of surgery in a little while. Or you may say, let's just get rid of the rectum, take the lowest risk approach and have a permanent ileostomy. But if I can get you to do a small exercise before we discuss what operation to do. And apologies if you've done this before, but I would like you just, every single individual, to imagine that sadly today you've been diagnosed with a terminal illness. And there are two treatment options available to you, both of which have been approved by NICE. So treatment A is a tablet that you take that gives you a 50-50 chance of either complete cure or a painless death today. So that's treatment A. Treatment B is you're given a similar tablet, and that gives you a period of time, X period of time, where you are completely well, in remission, no symptoms, nothing, and then you die suddenly. So my question is, how long does that period need to be? How long does X, in months or years, need to be before you choose treatment B rather than treatment A? So I think you've all got a piece of paper and a pen in front of you, and I'll give you, 10 seconds to just think about it. So any questions? Anyone not understand the question? So you have to write down a time period, a number of years or months. No conferring. Okay, I'm hoping everybody has written down a time period, and I would suggest you just show it to the other people on your table or to your immediate neighbour. I can't obviously ask everyone to read out their... Okay, it's not afternoon tea time yet, so please. Okay, I've done this exercise with a few groups in the past, and we did this with a group of young, recently qualified doctors recently, and the answers ranged from 6 months to 50 years. And interestingly, there were a couple who just recently got engaged, and their answers differed by 30 years. So they thought they knew each other. So my point of this is to say that we value different things in different ways, and it's very hard to know what different people or different patients think when faced with challenging decisions. And this dovetails, I think, sensibly with, many of you will know the situation with Nadine Montgomery, which has changed the law regarding consent and decision-making in this country. About 22 years ago, Nadine was pregnant with Sam. She has type 1 diabetes, and Sam was a large baby. She wasn't really given any options as to how to deliver. She went into natural delivery. She developed a shoulder dystocia problem, and Sam suffered a loss of blood supply for a period of time, to the extent that he was born with cerebral palsy. She sued the Lanarkshire Health Authority, and it ultimately went to the Supreme Court in this country, who judged in her favour, saying that the options were not explained to her in detail beforehand, and she wasn't given a free choice as to whether or not she might have a caesarean section with minimal risk of cerebral palsy, or a large baby, diabetic mother, and a shoulder dystocia, which led to the cerebral palsy. And this has now changed the law in this country, particularly regarding consent, and it's summarized by the GMC, which essentially says we, as doctors and nurses giving consent to patients, we must find out what is really important to that individual patient, rather than just making assumptions. So it involves a detailed dialogue with the individual patient before making difficult decisions. So coming back to the sort of hypothetical case, 25-year-old lady, should she have a pouch or something else? And essentially, rather than asking the questions, which operation, the question we should be asking is, what is important to this individual patient? Is it satisfactory bowel function? Does she have a job that doesn't give her sort of easy access to lose? Is sexual function or future fertility, fecundability important? Is the magnitude of the surgery at that time in her life, how quickly she might return to work, is that the critical thing? Is she worried about the future cancer risk if the rectum is left for a long period of time? Or is she worried, for whatever reason, about body image? And I'll just talk through some of the, if you like, the details of those factors to help make the decision for an individual patient. As I'm sure almost everyone knows, pouch function, people with pouches, bowel function is not normal. It will never return to perfect normal function, and a typical patient who's had a J pouch will open their bowels 5 or 6 times a day. Most patients will have to get up during the night at least once, and a significant proportion of patients have the most troublesome symptom of urgency or potential leakage. And there is, of course, a failure rate with J pouches, with between 10 or up to 20% of patients ultimately failing and either having abysmal function or reverting to a more high output ileostomy than they would otherwise have had. Another very important issue, obviously, in young women is fertility or fecundability, and there's been numerous big studies on this which have shown roughly a doubling or almost trebling the risk of infertility after J-pouch surgery. I'm not sure if that tells the whole story in the best way, and another way of looking at this is a very impressive Finnish study from a few years ago, which looked at 160 pouch patients, and they used an age-matched control group of patients who'd had an appendicectomy, and they were really only interested in those people who wanted to and were actively trying to become pregnant, slightly more in the control group than the pouch group. And if you look at the chance of becoming pregnant in the two groups, this is a natural pregnancy in the pouch patients. After 72 months, after 5 years, 76% of the women became pregnant naturally, compared to 91% in the control population who'd had an appendicectomy. If you then add in the option of IVF or fertility treatment, then the numbers change slightly so that the number in the pouch group goes from 76 up to 80% of women. So how we should impart this information to patients is difficult, and I don't know what the right answer is, and I usually tell patients both sets of information. Yes, infertility rates are roughly doubled, but about 75 to 80% of women can become pregnant after pouch surgery compared to 91% of the control population. So how we spin that is important, and that may well impact the decision-making or the timing of surgery in this sort of patient. Sexual function is almost certainly deteriorates after pouch function with increased symptoms such as dyspareunia, vaginal dryness, and the risk of incontinence. I mentioned briefly the option of an ileorectal anastomosis if there happens to be minimal inflammation in the rectum. There isn't a huge amount of data about fertility issues after ileorectal, but the data that there is, mainly from Scandinavia, suggests no change in fertility after an ileorectal anastomosis, whereas there is obviously an increased risk of infertility after pouch surgery. The ileorectal option was initially described, I think, in Birmingham about 60, 70 years ago, but fell into disrepute because the rectum was left in place, and over the years that increased the risk of malignancy. But in Scandinavia particularly, there's a renewed interest in ileorectal, especially for young patients with colitis, assuming they've got no significant inflammation in the rectum, no dysplasia, no risk factors for cancer, and are happy to have the rectum surveyed at regular intervals. And there's not too much doubt that bowel function after an ileorectal is a bit better than after a pouch operation, even if the pouch goes perfectly well. The other option for this 25-year-old patient would be to just hold off surgery and not do anything. There's no urgency. She's living perfectly well with her stoma. She can perhaps put up with the rectal discharge for a little bit longer. We have a vague rule of thumb that you should, after 10 years of an out-of-circuit inflamed rectum, you should, as the rugby referees say, use it or lose it. So either remove the rectum or put it back into circuit. The deferred surgery, there's obviously no risk, no change in fertility risk, and so it's the status quo, no change in the way that she is at the moment. The most radical option is obviously to remove the rectum and anal canal and have a permanent ileostomy. Surgically, that's the most straightforward to do, lowest risk surgery, but does probably have a negative impact both on body image and sexual function. The next slide shows a patient I've looked after for many years, who obviously his body image is important to him. Angie, I'm sorry, I'm told that other appliances are available. So, in summary, this young lady, it's difficult to know what operation to do. There are various options, each with their pros and cons, but the important thing, precipitated by the legal change with respect to consent in this country, so we really need to find out what's important to the individual patient. So I'm going to change tack. That's all I'm going to say about ulcerative colitis, and just some thoughts for the decision-making. We'll turn to Crohn's disease. I'm going to skip over my first few slides fairly quickly because they've been covered to an extent already this morning. But you know it's a chronic inflammatory bowel disease, can affect any part of the gut. The textbooks say it affects about 1 in 2,000 of the population, but certainly in the young age group, the sort of late teenagers and young adults, it's probably closer to 1 in 200 of the population. Again, there are genetic and environmental factors which have been discussed already this morning. Pathologically, you can see the skip lesions, you can see a normal bit, an abnormal bit, a normal bit, an abnormal bit, which is one of the hallmark features of Crohn's disease. You can see typical aphthous-type ulceration or the much more severe cobblestone ulceration in this picture. The main complications are strictures or fistulae formation. You can see a single stricture shown on an old-style barium X-ray here, or multiple strictures at various parts of the small bowel shown on a barium or MRI scan here. At operation, some of the sort of key features are fat wrapping. You get this encroachment of fat surrounding the bowel wall, which is absolutely diagnostic of Crohn's disease. There's no other condition that gives you this encroachment of fat. And you get new blood vessel formation over the thickened area with the fat wrapping. Again, I'm not going to go through the symptoms. The symptoms of Crohn's obviously depend on which bit of bowel is affected, how severely it's affected, and whether or not there are complications such as stricture or fistulae, or whether or not there are any of the extra-intestinal manifestations. So it's a disease that can be very easy to diagnose, although, as we heard tragically this morning, can be, disastrously difficult to diagnose and not diagnosed for many years. The classic triad of symptoms being abdominal pain, diarrhea, and weight loss. Again, the treatment options are outlined here. Probably 5-ASA drugs no longer used for Crohn's disease, but all of the others relevant at different phases of Crohn's. So we'll bring another case, a lady I was involved with treating a few years ago. She presented, 19-year-old, presented in September 2019 with symptoms of urgency, abdominal pain, bloating, bowels open once or twice at night, and a slightly raised CRP and a slightly lower hemoglobin. She was referred to a gastroenterology clinic where a fecal calprotectin was done, which was extremely high, CRP still raised, so the diagnosis of Crohn's disease strongly suspected. She had a colonoscopy, which showed inflammation in the terminal ileum. So if you cast your mind back to January 2020, just prior to COVID lockdown, a couple of months before that, she had an MRI which confirmed a 15-centimeter segment of terminal ileal inflammation, no proximal dilatation. She was given a short course of steroids. She felt very well. In February 2020, she was planning to have a year traveling around the world. She was going to go off to Southeast Asia, and because of that, for ease of delivery, she was decided to be given ustekinumab as biologic therapy, which was started. Little did she know what was going to happen in March 2020 and for the rest of that year, so she obviously didn't go traveling around the world. She stayed in the UK, but she was actually very well throughout 2020. She had a follow-up MRI scan towards the end of 2020, which was unchanged. And she was referred for a surgical opinion. I'm not quite sure why, but she came to a surgical clinic in January 2021. She was well. She'd had a few episodes of fairly short-lived, gripey, colicky abdominal pain, and she'd lost about half a stone in weight, but she was otherwise feeling well and taking regular ustekinumab. So the question is, what would you do at this stage? It's a simple toss-up, really. Carry on with ustekinumab, maybe change to a different biologic, or consider surgery. And I don't know if anyone has strong feelings. There isn't a right or wrong answer. There was no absolute indication for surgery, and continuing on medical therapy would seem very reasonable. So we've tended to avoid surgery if possible, and the traditional philosophy in Crohn's disease is it's an incurable disease. It can affect any part of the gut. It usually comes back after we operate, and surgery therefore should be reserved for complications such as tight strictures or symptomatic fistulae, or when medical therapy has unequivocally failed. So the implication is don't operate unless you really have to. And that view is supported by the fact that the drugs work fantastically. This could be the change with anything from steroids, azathioprine after a while, to any of the modern biologics. You go from an inflamed bit of bowel to a healthy bit of bowel. The data in the literature, again, supports medical therapy. This is one of the big trials of infliximab, the ACCENT-2 trial that showed the infliximab are in the pink. The number of hospitalizations and the need for surgery is massively reduced for patients taking regular infliximab. But we have a dilemma. Despite the wonderful drugs and the reluctance to have surgery, the vast majority of Crohn's patients during their lifetime will require surgery. As the years go by, more than 80, probably 90-ish% of patients ultimately come to surgery. And I'll just mention one more patient to illustrate that surgery can be miserable. And I warn you, I'm not going to show a not very nice slide in a moment. This was a lovely lady, 46-year-old Italian lady. She had a 7-year history of fairly mild distal ileal Crohn's disease. She was well nourished, enjoyed pasta. She wasn't on any drugs. She was a non-smoker. And she was admitted to a hospital as an emergency with a flare-up of right ileal fossa pain and a fever. And she underwent an immediate ileocecal resection for Crohn's disease. Unfortunately, 4 or 5 days post-operatively, she wasn't doing well. She had a drain which had been left, and some bowel contents came out into the drain. So it was very obvious that she'd leaked. She was taken back promptly to theatre, where a small, almost pinhole leak in the anastomosis was identified. There was minimal contamination, and the surgeon at the time thought it was reasonable to redo the anastomosis, but sadly her subsequent outcome was appalling. She leaked again and ended up with an abdomen like that. So we know that the drugs work, we know that surgery, traditional approach is to avoid surgery, but surgery has risks, but most people require surgery. So to get over that dilemma, I think we need to move from this traditional avoid surgery approach to thinking about surgery in a slightly different way. Acknowledge most patients will require it. Surgery should be thought of as one of the treatment options, and our job is to make the surgery as safe as possible, and ideally, if we can, reduce the risk of the disease coming back, if we possibly can. So just to address how we can improve surgical options, what are the risk factors? What makes surgery dangerous? There are numerous studies, and I've just picked out 2 or 3 of them to show what the main risk factors are. One study, from Birmingham, a long time ago, showed that undernutrition, steroids, an abscess or fistula at the time of surgery, the more you had of those risk factors, the greater the chance of anastomotic leakage. Very similar data from Paris. Again, they identified undernutrition, steroids, and an abscess at the time of surgery. All of those risks, the more of those risks you've got, the greater the risk of anastomotic leakage. We looked in Oxford at a cohort of about 173 patients, and we only looked at these 3 major risk factors: steroids over 10 milligrams, sepsis, and undernutrition. If you had none of those risk factors, we had no leaks or intra-abdominal sepsis. If you had 1, the leak rate was 10%. If you had 2, 25%. And in one case, for some reason, we joined the bowel together and it leaked, 100% of 1. So the risk factors these are the major risk factors to consider in undertaking Crohn's surgery. The other is emergency surgery. This is data from a national audit that in this country, this is not inflammatory bowel disease, this is all comers having emergency laparotomies in the UK. The 1-month mortality is 15%, which is pretty much the same as plain Russian roulette. So emergency surgery should be avoided if at all possible. Why did this lady leak? The reason why she leaked was that she had a tight anal stenosis. We all know that Crohn's can affect any part of the bowel. It quite commonly affects the anal canal. She had a tight stricture in the anus, putting back pressure on the join. That's why it leaked. That's why it leaked again when it was redone. So somebody should have checked. So we have a sort of checklist prior to Crohn's surgery, which is I've sort of summarized here. In preparing a patient for surgery, we try to address these 3 major risk factors. If patients are on steroids, you've got to reduce the steroids to a low rate, get it under, at least as low as possible, but under 10 milligrams for at least a month. Enteric nutrition, ensures or similar, can be used as an exclusive enteric diet to allow you to bring steroids down. And there's actually the so-called OCEAN trial, just mentioned here, which Tom Pinkney's group have got funding for recently, which will be opening, I think, probably later this year or next year, looking at the outcomes of Crohn's of exclusive enteral nutrition prior to Crohn's surgery. Sepsis needs to be addressed as best it can be with antibiotics, radiological drainage of collections, and the best markers of reduced sepsis would be a normal CRP and a normal albumin. Albumin's a better marker of sepsis than nutrition. Nutrition, weight and BMI, you really want a stable weight rather than a decreasing weight coming into surgery. And nutritional, if you're losing weight, then you need some form of enteral or parenteral nutrition planned preoperatively or as a contingency for postoperative usage. I think it's also important to have recent imaging and a recent endoscopy, a colonoscopy, or at the very least a flexible sigmoidoscopy to make sure that there isn't unexpected distal obstruction. Because if you do a join and there is distal obstruction, the join will leak. Manage anemia in the usual sort of way, and I'll come back to it as we've heard already today. Stopping smoking is important. Unfortunately, this all sounds great, but sometimes we can't correct all of those risk factors. And if we're faced with a patient with high risk, we can't get them off steroids, they're undernourished, they've got grumbling sepsis, then essentially, if they still need to have an operation, don't do it all in one go. Don't join the bits of bowel together and accept a two pit stop strategy, a two operation, a temporary stoma, and then when the patient is well, off drugs, well nourished, then join the bits of bowel together. And I think I would encourage you to encourage your surgeons to make decisions about needing a stoma or not a stoma prior to surgery rather than during the operation. There's been a tendency for surgeons to say, well, if all goes well, it seems fine, we'll do the join. If things aren't going so well, we won't do the join. There's really no unpredictability. You know if the patient is septic, you know if the patient is on steroids, you know if they're undernourished, you know what you're planning to do. If the risks are too high, then discuss it with the patient in advance and make a planned stoma. I've had several patients one patient I remember who in the end I didn't make a stoma, although I'd planned to, so I'm shooting myself in the foot, but he was actually quite upset with me for not making a stoma, even though his subsequent course was absolutely fine. So I'd taken a risk that he wasn't really prepared to take a risk. So I think decision-making in advance with the patient agreeing to it is the correct approach. Finally, I'll just say a little bit about reducing the risk of recurrence after surgery. Sadly, Crohn's will come back in the majority of cases. If you look endoscopically, it comes back within 6 months in 80 or 90% of patients. If you look at surgical recurrence rates, it's 30, 40% at 5 to 10 years. So Crohn's does have a tendency to come back. Endoscopic recurrence is a really good predictor of later clinical or surgical recurrence. So what can we do? We've heard a bit about smoking already. This is a study we did jointly with St. Mark's and a hospital in Sweden. We looked at 242 patients having ileocolic resections for Crohn's disease over a 12-year period. 70% were non-smokers, and the recurrence rate was 17%. That's a clinical or surgical recurrence rate. The ones who were smokers and continued to smoke had, by far and away, the highest rate of clinical or surgical recurrence. But encouragingly, the ones, albeit only 13%, who quit smoking at or around the time of surgery had the lowest rate of recurrent Crohn's disease. So if you can encourage and give the appropriate support to help patients stop smoking, the time of an operation is a good time to make that point. Another major sort of change in practice in the last sort of decade or so has been based on this very impressive Australian POCER trial, which basically randomized patients to no planned endoscopic follow-up, but best medical therapy as they judged following the surgery, versus a planned colonoscopy at 6 months, and then basing the need for drugs, particularly biologics, on the findings at colonoscopy at 6 months. And at their primary endpoint was endoscopic recurrence at a year and a half, and there was a significant improvement in outcome in the patients who had had tailored therapy based on a 6-month colonoscopy. So the default position now, I think, should be every patient having a Crohn's resection should stop smoking and should have a colonoscopy at 6 months with a decision to escalate or change or start biologics at that stage based on the endoscopy findings. As surgeons, we like to think we make a difference, and if I was giving this talk or a similar talk 5 years ago, I could advise you to just doze off and have a little rest for 5 minutes, because what I'm going to say for the next 5 minutes, surgery doesn't make a blind bit of difference. The way whether or not we do it robotically, keyhole, open, whether or not we resect lots of bowel or minimal bowel, whether or not we resect the mesentery, or how we join the bits of bowel, does not make one iota of difference. But interestingly, in the last few years, there's a bit of evidence, which I'll touch on, that suggests maybe the surgical technique does matter. But I'll show you the first bit. The laparoscopic versus open approach makes no difference whatsoever to recurrence of Crohn's disease. The way we do the join, whether or not we do an end-to-end join or a very wide side-to-side join, doesn't seem to make any difference. This was a North American trial run by Robin McLeod from Toronto, which was a really impressive, well-designed trial, which showed no difference in either leak rates or subsequent recurrence of Crohn's, irrespective of the type of anastomosis. And that was one of the studies that fed into numerous national, international Cochrane Library guidelines. The Cochrane group basically said, it doesn't really matter what surgeons do, whether or not you do how you do a join, interrupted, hand-sewn, stapled, wide, side-to-side, robotic, keyhole, doesn't make a blind bit of difference. Do whatever you fancy. Similarly, the American College of Surgeons, their guidelines, anastomotic technique doesn't matter. Do whatever you like. When Crohn's was first described in the 1930s, for the next couple of decades, surgical resections were done a bit like a cancer resection, with a very radical, wide resection of margins, sort of 10 centimeters of bowel on either side, plus a radical mesenteric resection, and that led to problems with short bowel syndrome. That was supported by some Scandinavian studies in the 1970s, which seemed to suggest lower occurrence when you did more radical resections. And then in the 1980s and 90s, there was a very definite shift in philosophy of surgery for Crohn's disease towards minimal resections. It was noted that if you had microscopic inflammation at the margins, it didn't seem to matter, and that supported just resecting the obviously diseased bit with the minimum macroscopic margin and doing whatever join you wanted to do. And that was supported by a pretty landmark trial from the Cleveland Clinic in the late 1990s, which basically randomized patients to a standard, at that stage, limited resection with just a centimeter or so of normal bowel at the edge of the diseased bit versus an extended resection with a 12 centimeter margin at the edges of the resected bit. And that showed no difference in surgical recurrence rate. So that reinforced the currently felt view that surgery for Crohn's should be preserve bowel length at all costs and just remove the minimal amount of bowel. And that's still pretty much the philosophy today. So you need to wake up again for a second. There's just a little bit of evidence coming through, mainly from Japan. This surgeon, Toru Kono, who very sadly died a couple of months ago, but he described a different way of joining the bowel together in Crohn's disease. And just diagrammatically, what he recommended was, if this is the strictured segment and you're resecting from there to there, so a close mesenteric dissection, you then staple the two ends off transversely, and then you sew those two stapled off ends together. So you've got two closed off bits of bowel sewn together. You then make a longitudinal cut 7 centimeters on either side of where you've sewn together the stapled off bits, the so-called supporting columns, and then you sew that hole to that hole, but transversely. So you sort of pull that bit out that way, and hold it transversely, and then you sew the back wall together, and then the front wall. So diagrammatically, you can see the two stapled off ends stapled together, the two enterotomies being held transversely, and then the back wall sewn together, and then the front wall. So again, diagrammatically, the back wall being sewn together, then the front wall, so you end up with these supporting columns at the back and a very wide join between the bits of bowel. And possibly the important concept is that the join is kept well away from the mesentery, where there may be metabolic activity which drives recurrent disease. And his results which are published, are absolutely remarkable. His recurrence rates are at, I can't remember, sort of 10 years or 12 years, absolutely zero surgical recurrence rates for Crohn's disease using this so-called Cono-S anastomosis. His results have been not quite reproduced around the world, but still pretty encouraging results. One of the few randomized trials of this was an Italian trial published just during the start of COVID, which showed a much lower endoscopic recurrence rate, 20% recurrence versus a more standard 62% endoscopic recurrence at 6 months. So there may be something in this new technique which is important. Now, to confuse things, this is another surgeon from Limerick in Ireland, Calvin Coffey, who he popularized the idea of a much more extended mesenteric resection. So instead of, this would be a fairly standard close dissection. So this is the diseased bit of bowel, and the cut is close to the bowel wall, as opposed to this, which is a more cancer-type resection, where you resect the adjacent mesentery with the various blood vessels and lymph nodes and do the same join. And his results show a much lower recurrence rate with the extended resection compared to the more standard recurrence rate of sort of 20-30% after a minimal Crohn's resection. His results are non-randomized, and they're a retrospective study, but it slightly ties into the concept that there may be something. We've concentrated on metabolic activity and an inflammatory process in the bowel wall, but there may be something going on in the mesentery which causes this initial fat wrapping, and metabolic activity in this area may be driving the Crohn's disease activity, and in particular recurrence after surgery. So there's now a UK-based trial which hopefully will be starting in the next few weeks, literally. We're hoping to be one of the first sites in the UK to take part in this so-called MEERKAT study, which is basically randomizing both the extent of mesenteric resection, either a standard close dissection or a more radical cancer resection, and also a Cono-S versus a more standard stapled side-to-side resection. So there's 4 options within the trial, and that should answer objectively the question of how important the surgical technique, both the anastomotic technique and the extent of mesenteric resection. So to summarize, as far as reducing recurrence, stop smoking. Standard practice should be colonoscopy at 6 months to decide on biologics, unless there's a clear reason to be giving biologics post-operatively. And hopefully this MEERKAT trial will give us an answer to this question. So I'll summarize by just sort of going through what I've said before. Ulcerative colitis, very different disease to Crohn's disease. The decision-making is challenging. Thanks to Nadine Montgomery's change to the law in this country, we've been encouraged to communicate better with patients, find out what's really important to the patient, and make the appropriate decision as a result of that. Crohn's, I think the pre-op checklist is crucial, and I would encourage people to literally go through a sensible checklist, make sure all the checks and balances have been done. But in principle, get the patient off steroids, avoid sepsis, correct nutrition, but if you can't, go for a 2-stop strategy and make a temporary stoma, but make that decision in advance. And I've just said that that's reducing the risk after surgery for Crohn's disease. So, thank you.